Good evening, everyone, and welcome to our latest edition of the Health and Wellness Town Hall presented by the College Park, Sandy Spring, Maryland Alumni Chapter of Kappa Alpha Psi. I'm Paul Bias, and I'm pleased to bring you this evening our presenter, Dr. Dambita from the African American Health Program. Dr. Dambita's subject matter is diabetes, prevention, and cures. So, Dr. Dambita, we will turn it over to you.
Okay. Thank you so much, Paul, for inviting me to come and talk to the brothers this evening. I understand your alumni. I wish I'd graduated with, I wish I'd gone through the whole training and whatever, so I could be an alumnus like you. But we are all brothers, and so I'm very happy with that. I'm going to talk about diabetes tonight. Let me go on presentation mode.
It's down at the bottom. You should be able to get the button down at the bottom right corner. There's an icon.
Yeah. Okay. Slides is
Under, let's see, if you go down under where you have "We Are Stronger Together."
We're Stronger Together. It's not
right in the,
yeah,
yeah, it's the fourth icon over from the notes.
Yeah, let me make this smaller. So I can
keep
back to here. What happened to my?
No, next to the slider. You were on the slider, but if you go over to the icon next to the slider, where you were.
No, here, let me see if I can help you. Just bear with me once.
That was
Actually, from the menu, click view. Click view from the menu.
I can't see the menu. Okay, I know what is happening. This thing should be at the bottom. There's a band here. Okay, let me move this down. Now I can see.
Okay.
Slide show
There
right
you go.
from the current.
There you go.
Okay. In terms of introduction, I'm a public health physician. I've been doing this for nearly 4 years now. And for the past 7 years, I've been the clinical director of the African American Health Program. And I found my passion bringing together all the different experiences I've had across the years and across different disciplines. And particularly when we talk about diabetes, I have a personal experience with it. First of all, I've had some family members with diabetes. And I'm purposely saying with diabetes. We no longer talk about people with diabetes as having as being diabetic. Diabetes does not define you. You are not something that diabetes transform you into. You have diabetes. Just like we wouldn't say for someone who has cancer, we're not saying they are cancerous. We say they have cancer. Same thing with prediabetes. So if you can keep this in mind and sharing with people and correcting people so that they can have, that's part of the effort of doing something about diabetes. Because indeed, it is a terrible, it is the biggest epidemic we have going. We had it prior to COVID, and it's still with us after COVID, and it's getting bigger. So I have 2 watts today. What are we talking about? We're talking about diabetes, and we're talking about prediabetes. I am going, sometimes you'll see me up, moving up a little bit. Sometimes you'll see me sitting down. That's my way of cheating. When I don't get enough steps, like today, I've been working all day. I've not had a chance to be outside and do some exercise. So when I'm working, I'm trying to get those 10,000 steps in. And that's also one of the strategies of combating diabetes. So let's see when we talk about diabetes, what are we talking about? It is a disease in which the body does not produce insulin or uses it inefficiently. We all know that. In our lingo, we said we have sugar. And yes, we do have sugar, actually too much of it in the bloodstream. And that's not where sugar belongs. The reason why I'm saying that is sugar is our source of energy. It belongs in cells, all kinds of cells, brain cells, muscle cells, to do what we need to do every day to live. And in order for that to happen, a key is needed to open up the cell for the sugar that we eating. When we eat, we break everything we eat into sugar. For that energy to enter the cells, it needs a key. The key is called insulin. It's an hormone. If you have all the keys, they open all the cells, and sugar is happy to go do its work. If for some reason, when I say it uses it inefficient, when you do not have that key at all, that's one of the types of diabetes. That's type 1. You need to have that key from an external source, and that's insulin. Sometimes you have it, and you have what it is that happens. It's called, the body becomes insensitive to insulin. And what happens is just like with your key. Sometimes you wiggle it so much that that key does not turn automatically. It does not open. So that insulin is there, it exists, but it cannot be used. That's one example of using insulin inefficiently. Now, the other thing we've talked about, let's see. Now let's look at and I'm giving a broad category here. There are the two types I mentioned, the type 1 diabetes, and that's usually a genetic thing that happens. It's hereditary, and right from infancy, you can tell that that person does not have an effective pancreas. The insulin, that hormone I was talking about, is produced. There are several organs that actually produce insulin, but the main source of insulin is the pancreas. More precisely, the beta cell of pancreas produces those key that we need for the metabolism of sugar. Now, there's a little bit of it in the stomach as well, and in on the kidney. And when there's something wrong with the pancreas, there's no insulin at all. Talk about that. But when we're talking about the one that we can do something about, that's the majority. That's type 2 diabetes. It's the one that there are some factors that you can do to prevent it. Unlike type 1, where is none. And many of the things that you can do to prevent it: moderate exercise, and me doing my step, or sometimes in front of the TV, or playing some music on YouTube and dancing. that's moderate exercise. And keep moderate, give appropriate body weight. That's one of the strategies. And eating a balanced meal every time. And that through this, you can prevent, you can delay or prevent diabetes. And then there's a third type of diabetes, and that happens again during pregnancy. And if a woman, it's called gestational diabetes, happens during pregnancy because of the big hormonal storm that occurs within during that period in the life of a woman. And that predisposes them to have diabetes later on in life. So there are other minor types, but just keep the 90-10% in mind. And there is a good reason that you want you to keep that number, 90-10, 90-10, 90-10. Many aspects of the diabetes we're going to talk about deals with that actually. And there are other types. One is LADA, that's latent autoimmune diabetes of the adult. And that happens, it's due to modification of one gene. Same thing with the other that is called maturity onset diabetes in the youth. It's one gene. In the other, in the type 2 diabetes, multiple genes, several genes, polygenic, right? So who's at risk? And that's something we need to know. We need to know if looking at all of us here, we are over 45 years old. That's a risk per se. That means age has something to do with it. Leading a sedentary life when you're not exercising at least 3 times a week, and moderate exercise, that predisposes you. If there's a family history of mentioning to you my personal journey as well. I have people in my family that have diabetes. And just a few years ago, I discovered that I too have prediabetes. And knowing about the history, about the risk factors, helped me to actually kick it to the curve. For now, my A1C is normal, within normal range. So I don't have anything to fear right now, but I just have to maintain whatever I'm doing, whatever I was doing. And I did this without medication. We'll come to that in a little bit. So family history is important. And diabetes loves company. Most people that have diabetes, they also have high blood pressure. Okay, they go hand in hand. And you have high blood pressure, chances are high that you have high cholesterol as well. And we mentioned earlier that the history of gestational diabetes predisposes someone to have diabetes later on down the line. And then controlling weight definitely is a factor. So that's who is at risk. So you can have all those predisposing factors. It predisposes you, but it's not predetermined. You will not necessarily get diabetes because you have one or several of those risk factors. But it's a call to action for you to do something about it. And the symptoms, often those who have it, it's fairly, everybody knows, you understand that you will urinate quite often, you feel very thirsty, drinking all the time, feeling hungry at the same time. And it explains it, because those cells are not getting the energy they need. They're not getting the energy they need, so they have to seek other sources more and more. And the more you accumulate those the sugar in the blood, all this excess sugar will lead to even more weight and will accelerate certain processes in the body that will make diabetes emerge and then become a serious, lead to serious complications. So fatigue, you're not getting enough energy, so it's natural to feel fatigue, extremely fatigued. Blurred vision, because those sugar deposit in all tissues, all cells, and everywhere they go, they will affect it. It affect the eye. The normal process of healing when you get a cut or a bruise is also disrupted. And for some reason, many people believe that you have to be big to have diabetes. That's wrong. You can be thin, you can lose a lot of weight, even though you're eating, as it happens in a type 1 diabetes, but it can happen with type 2 diabetes as well. You start feeling with type 2 diabetes, tinglings and pain and numbness in your hands. So that's what we call neuropathy. And how do you diagnose it? It's easy. You take they check your blood sugar level, and if it's exceed at fasting, if it exceeds 126 milligram per deciliter, that means yes, you need to do another test. This is a screening test, but then to confirm the diagnosis, you need to progress to doing maybe an A1C or an oral tolerance, glucose tolerance test. And another thing is, if you, in addition to that, if you begin to experience some of the symptoms that I just mentioned a few minutes ago, and they do a random blood test for sugar and it exceed 200 milligram per deciliter, and you know that that's you have diabetes. That's a definite, one of the definite. You need two of those to have a definite diagnosis, definitive diagnosis. And to manage it, we'll emphasize lifestyle changes. That's where to start. Otherwise, your doctor will more than likely put you on metformin if you have type 2 diabetes, or depending on how high your A1C level is, you end up having to have insulin injected on a regular basis, daily actually. And yeah, there are all kinds of technology now. Say, for instance, with the Dexcom 7 or the Libre, where you have this monitor that linked with a insulin pump, and when your blood level, the sugar blood level goes high, automatically it will inject gradually the amount of insulin that you need. So those are called the injectable. And if it's type 1, there's nothing you can do about it. You have to have insulin. So let's talk about the management. It's what we call the 7 pillars of controlling managing diabetes, and that doesn't come from me. It comes from the American Diabetes Association. Got to eat healthy. You have to be active, and you have to do monitoring of your blood on a regular basis. It is important. We'll see this in a little bit. And you have to take medication, the medication prescribed by your doctor, and teaching you to problem solve. Problem solve is an example. You feel, you know that you are experiencing some of those symptoms of hyperglycemia. You do something about it. Either it's time to take your medication or you didn't take enough of it. You can do something about it. You solve that problem. Reducing those risks, there's multiple risks that we mentioned, and learning to cope, because there is a mental health component to managing diabetes, and that has to be addressed. Because you're in that fog, you feel frustrated, you feel depressed, and that can lead you to fall back into the detrimental behavior that you're trying to control. So let's talk about why it is important to monitor your blood glucose level. That's the only way to know that it is in a range. In a range, that's a terminology that you hear often. It's usually between 80 milligram per deciliter and 130. If you have that, that means it is controlled, and you will know it. So, in other words, the only way to know it is because if you can test yourself. And the reason why it is so, it's if you rely only on symptoms, that's not a very reliable way to know that something is happening. Many people, in fact, if already with diabetes, do not have any symptom whatsoever. So it is important to monitor your blood. The benefits are multiple for monitoring your blood. It helps you to, one of the things, if you join one of our programs, is that you learn to set targets, to set goals, and to bring that level of sugar within range. And it helps you to prevent or detect when the level has gone too low or too high. And it may show you how food that you eat. If you eat a lot of carbohydrates, yes. Learning about glycemic index. Each food is on that scale of glycemic level. Glycemic index is important. You take something, and what that means is how quickly the food you're consuming turns into sugar in the body. A food that has very high glycemic index, you should avoid. Just table sugar. Yeah, it's really very quickly going to raise your sugar level. May not stay there long, but it will do that, and that's not good. Potato also has a high glycemic index, but not sweet potato. Sweet potato goes into the blood gradually. Okay. Orange juice goes in quickly, but if you eat vegetables do not have something like watermelon, some fruit. Watermelon, believe it or not, have very high glycemic index. number. So when you learn all these, you have this table to consult each time. It does help you. Your activity level also affects your blood sugar level. And the only way to know it is you're able to monitor. And it helps determines where you need to make some changes, either with your behavior or with medication or whatever. Let's see. Okay, we talked about the target already. It's in the morning. If you're fasting, being in range is between 80 and 130. And after eating, it should be less than 180. 2 hours after having a meal, your blood level should be below 180. Okay, let's talk about, we talk about hyperglycemia. Hypoglycemia is also important. It's when it's too low, when it falls below 70 milligram per deciliter. And the causes are, for someone who has diabetes, is if you delay meals. Not only if you delay meal, all of us, if you fast throughout the day, you begin feeling this headachy, you can shake, you can become irritable. All these an indication that your blood glucose has fallen below 70. Sometimes to correct hyperglycemias, you may take too much of your medication, or you took it without adequate intake of carbohydrate. That's one thing that the medication does, is to bring that level down. And sometimes it can bring it down dramatically. You want to be able to have some carbohydrate to go with it as well. And physical activities, if you over exert yourself, that sometimes can bring it down. Alcohol is bad, or some illnesses can bring your glucose level down. So what are the signs of hypoglycemia? You feel hungry, of course, because you haven't had anything to eat. You feel weak and tired. You get the headache, irritable, and you may or may not experience any of those symptoms, but usually that's what is happening with hypoglycemia. You feel shaky and sweaty, dizzy, and confused. That's you'll be able to your body will tell you, will give you that message, and you know what to do. Hyperglycemia, on the other hand, it's when it's way out range there in the 250 milligram. Again, what causes it is not taking medication, or taking too little of it, or eating a lot of carbohydrates. So, how do we want to treat hyperglycemia? How, if it goes high, how do you manage it? Did you take your medicine? If you have not, go for a walk. This is for hyperglycemia. Go for a walk. Drink a lot of water. Water is really good. Water, you should consume at least 64 ounces of water a day. But stop around 6 o'clock, because if you wait, you drink just before going to bed, guess what? You'll wake up several times during the night. And when you do that, that disturbs your sleep, and not sleeping, not resting, also fuel the diabetes cycle. So minimize your intake of carbohydrate and recheck your blood sugar after 1 or 2 hours. And if it still stay high, that means you're moving into an emergency area. That's the time to call your healthcare provider. Call your doctor if it stays high, even after taking medication. And or if you start having pain in the belly, and start vomiting, start having nausea, if you start feeling sleepy and confused, you know it's time to call your doctor. Okay, so that's what diabetes is about. Diabetes, it's presented. I did not even go into the complications of diabetes because we try to keep this within half an hour. Let me quickly now go to the second one. The second one is about pre-diabetes. What is it? Some people call it baby diabetes. And remember I told you to keep in mind 90 and 10. Oh, I'm going to give you some figures. You think that 30 million Americans are walking around with diabetes. That is bad, right? But not nearly as bad as the next wave of people with diabetes that are coming, that all the pharma industry, all the industries that are in the business of diabetes, and we're talking about billions and billions of dollars, probably $260 billion that it cost to in diabetes. Just that one, that's a quarter of expenditure, healthcare expenditure in America. A quarter of it is devoted to diabetes-related disease. So the industry has vested interest in having a large population of people with prediabetes. And that's, I don't know if it was planned that way, but you're not going to go to your doctor and they're going to do a test for prediabetes automatically. Sometimes they may not think about it. Clinicians now are becoming more aware of checking for prediabetes, but only 10% of the 86 million Americans that currently have prediabetes, only 10% know that they have it because it's not done routinely. The other 90%, since there are no symptoms, since there are no, they don't go, the insurance company sometimes doesn't even allow for you to reimburse for a simple screening test. But I've designed my own screening test, which mirrors what the CDC is doing. And I believe I have the link at the end of this presentation. It asks you 10 questions, and you can find out whether you are among those 90% of the 86 million that are walking around with prediabetes, don't know about it. So what it is a silent precursor of diabetes, and 1 in 10, if 1 in 10 people have diabetes, and we are projecting that 2 years from now, 1 in 5 could have diabetes if there are no changes made. And the 80 million, I made these slides years ago, but the figure, more recent figure, is that 86 million have prediabetes. And there is a little improvement, only 11%. But for the sake of remembering, just remember the 1090, okay? And it will lead to type 2 diabetes within 3 to 5 years if nothing is done. If you know that you have prediabetes, you don't do anything at all about it, within 3 to 5 years, it will progress to diabetes. You go do your A1C level, that will be at above 6.5%. And that's it. That means you can't bargain about, I'm just going to change my lifestyle and so forth. It's too late. You have to be put on medication to bring it down. So again, guess what? You're familiar with this slide. It's the same risk for type 2 diabetes that you have it. So if you know it, you have over 45 years old, you're not actively doing exercise, you have family history, you have high blood pressure, or for a lady, we have some ladies in here, if the history in your youth, you've been told that you have gestational diabetes, and if right now you can have your BMI, that means your weight is, you're overweight, and you are not making the effort to reduce. Yes, that's it. You are the big diabetes industry is just waiting to welcome you and welcome your pocket rather. So that's it. So 5 to 15 times, if you have prediabetes, 5 to 15 times, you are more likely to develop type 2 diabetes. And that also, what comes with it is the risk for heart disease, the risk of stroke. Those are some of the complications, the risk of kidney disease, all that. And as the healthcare expenditure, I have the figure here. People with diabetes, the country spends 2.3 times more on them than the other people with the other disease. And the other people means people with cancer, with other illnesses. Yeah, you see, this is a good business to be in. So the signs are just the same. I need not repeat it. You will have higher than normal blood sugar level. You will feel the fatigue. You will have wounds that are slow to heal. You have wild swings of mood, problem with vision, begin gaining weight, frequent urination again, dealing with digestive issues, bloating, constipation, diarrhea, excessive thirst and hunger. All those are the signs to watch out. So I think I'm within my, I've exceeded the 30 minutes. So let's, I'm gonna stop here. I wanted to talk about the DPP program, but maybe during the discussion we can talk about that.
All right. Well, thank you so much for that information. Dynamite presentation, a lot of helpful information, and I'm sure our viewers found it as helpful as I did. So what we'll do now is we'll move into the question and answer period. There are questions in the chat, and I will just remind our guests, if you have a question, you can feel free to type your question in the chat, or you can use the raise hand feature, which is one of the reaction buttons. And if you raise your hand, I'll recognize you in order. But the first question we have is your opinion, Dr. Dambita, on intermittent fasting and what role it may or may not play in diabetes prevention and management. So if you wouldn't mind addressing that question.
Yes, it's, my own program is evidence-based. And I've heard, we have not done it, but I've heard that it has helped some people. And I think the thing to do is to also do like the DP program that I'm talking about, came from evidence-based. It's actually a clinical trial where you put people who have pre-diabetes, split them into 3 groups. One group, they get the normal treatment. Your doctor, more than likely, will put you on metformin. The second group is what is called lifestyle change, okay? And the third group is just receiving placebo. Instead of metformin, they receive placebo. That study was supposed to run for 2 years. After 1 year, they realized that the folks in the lifestyle change, 58% of them were actually doing better with prediabetes. That's a 58% improvement. And if you happen to be over 60, like myself, the benefit is even greater. That's 71%.
Wow.
Yeah. And they have to stop the clinical trial that involved thousands of people across the nation. Said, okay, we on to something right now. The evidence is there. So we're gonna prepare the nation to begin enrolling in the diabetes prevention program. And we do have one such program. And I was mentioning, I may not in the earlier presentation, that we received a great gift today from the CDC, recognizing us as a national accredited center for fully accredited for 5 years. So we will continue to do that. We have excellent results. So to go back to the initial question, intermittent fasting, yes, it seems to go together with some of the things that we talk about, as the idea is to reduce intake of, boils down to the reduce intake of food, fasting for a period of time. And if after the fast, often what happens, people begin splurging again. And does that happen when people stay in intermittent fasting for a long period of time? Could we design a study and test it out? And maybe that could help a lot of people, because there is not enough DPP classes around the nation to take care of 86 million people. So whatever else evidence that comes to light, I'm ready to try it out.
Excellent, thank you. And just as a follow-up, there was a question in the chat about whether or not or how sustainable fasting is. So would you say if somebody went the route of intermittent fasting or some other type of fasting program, in terms of sustainability, is that something that people should consider?
Yeah, the sustainability is one of the question that I have about those. Is it, and I know that some churches do it, and during a certain period of time during the year, but it's not done continuously. What I am preaching and what we try to do is to change lifestyle for the long haul, for a long period of time. If that can be sustained, then I have no problem at all. And you still need the support. The success we're having is that you have that support system in place, be it from us, we have a team dedicated to that, or through given a cohort of people that exchange, that talk about that, they can sustain. If within a church, health ministry, they can, or within a fraternity, people can support one another say for a course of a year and see what happens. I think that we will have the definitive answer.
Great, thank you for that. We have another question about, it looks like type 1.5 and type 3 diabetes, and you may have covered that in your presentation, but there was a question about those.
About
I think it's type 1.5 or type 3 diabetes.
what this I heard during COVID, there was some mention about maybe it came to light in some studies, limited in scope actually, that people with COVID had a predisposition of having diabetes, or does accelerate, and vice versa. The two are playing with one another, and they call that type 3. And that has not caught on yet. It has not, it's not a scientifically proven fact. Type 1.5, that's the first time I'm hearing it. Again, I'm still sticking to the orthodoxy of diabetes, type 1, type 2, gestational diabetes, the LADA, and the MODI.
Okay, great, thank you. So another question was, how important is it for patients with diabetes to have eye exams and foot care? And would it be advisable, or is it safe for them to have pedicures?
It's very important to have your eyes checked and to see a podiatrist about your feet. We so often neglect eye health and feet health. That's very important. Now, the thing with pedicure, they gotta be careful, because if the process of diabetogenesis has begun, and you have untrained hands that is roughen up your feet and so forth, and causes bruises. Remember, one of the issues that we have with that is that it's very slow to heal, and you don't want to do that, because invariably, if you have diabetes and the process continues, you don't want to be in a position of that small bruise becoming a large wound, becoming gangrenous, and having to lose a limb, because that's what happens when you go into hospital. Just go to a hospital and you see the people that are being discharged, many on wheelchair with a limb lost. That's diabetes. And you look at them, look at how those people are coming out of the hospital. Most of us are people like us, mostly Black people. So that means we're not managing our diabetes properly.
All right, thank you for that. Another question, I think this is in relation to some of the statistics that you quoted about the DPP program, it being 58% effective, but lifestyle medicine was found to reverse diabetes, if I'm reading this right. And so the question is, in your DPP program, did you find the same outcomes?
Oh, absolutely. This is a third cohort we starting this evening. I was there to introduce it. The first cohort is 2 years ago, and we had 14 people who signed up for the DPP. We had then a interim accreditation. Of those 14, 2 of them dropped off, and we continue with 12 people. At the end, 9 out of 12 reversed prediabetes. They left, and that's the reason why the program lasts a whole year. And you have to inculcate those behaviors and have people maintain it over the long haul. Yes, it happens. Second year was last year. More people joined in 18, and as with everything else, 4 of them dropped off. We ended up with 14 people. Among the 14 people, those who really adhere to the program, 12 of them or so, among those 10 of them reversed prediabetes. And that's why we got that, full recognition for 5 years. And we are starting a third one now. And if any of you hear that you amongst those 86 million, the 90% that do not know yet whether you have prediabetes, have that check, take the CDC test, and it's just a questionnaire. It will tell you right away if you score high enough, and you can do something about it. And you don't have there are more and more DPP classes around the county. Join one of those. Really, it's for your health, for the health of your family.
Wonderful. Thank you for that. Another question, should everyone with diabetes be referred routinely to an endocrinologist or a diabetes specialist?
Yes, and I tell you what, that's the best way to have a complete checkup to see how well your kidneys functioning, whether or not the level the factory, your pancreas, the factory that produces insulin, if it's working properly, and also because there are some other comorbidities that come along with it, and a specialist is the right person to visit from time to time, and your primary care physician will make that determination whether or not it's time to refer to an endocrinologist.
Okay. All right. Thank you. And we've got a couple more. Someone writes, I have found that the monitors, and in parentheses it says G7, have been invaluable. It allows me to track the foods that instantly raise blood sugars and to immediately react to low and high readings. What are your thoughts?
Absolutely, I applaud that. And you're a winner, and your insurance company is a winner because they allow it. Because not all insurance companies will let you have one of those. And keep up with it. And I hope that it comes with the one with the insulin pump as well to go with it. If you have that, and then again, re-emphasizing lifestyle change, then you're on your way to better health.
All right, thank you. There is a note that they're expensive, so it is good if your insurance will cover it. So I would imagine that that's considered not a necessity, which is why the insurance companies may not cover it.
And for the life of me, I do not understand why they're denying those. And it's there are some therapies, you've probably seen them on TV being advertised and so forth, putting pressure on physicians to prescribe those. I'm talking about the Ozempics of this world, because of the one of the side effects is weight loss. So Ozempic actually, and this type of medication has put is that Jenny Craig out of business because the weight management side of industry has taken over that. And since it's so expensive, it became the drug of choice for rich people, for Hollywood stars and so forth, who just want to use it for weight loss. And so all these things, it's difficult to really navigate the the appropriate and the right, and that to do justice to the people who are suffering with diabetes.
Got it. Got it. So there's a comment in here about asking you to talk about the risk for kidney failure and/or dialysis.
Yes, and it's a very good question. It's very important. It's one of the complications, kidney failure. Remember, it goes back to what we talk about, urinating a lot, and the thirst and so forth. You are taxing the kidney, and it does accelerate the damage. That means more and more sugar is floating around your blood, and you need eventually it does, with the great effort that your kidneys producing, those cells begin to become inefficient, and then they die off, and eventually you begin having the beginning. And this is a thing with there are different stages to kidney disease. At the beginning, when it's still in one, there are 4 stages. One, you can still try to do something about it. When it progresses, when it reaches stage 4, when your kidney functions maybe at 10 or 15%, there is no other choice that somewhere along that trajectory, you're going to have to be put on dialysis. And dialysis, it may, along that trajectory, is maybe once a week, twice a week, 3 times a week. And that, that the kidney is really damaged. And the only solution at that point would be a kidney transplant. And it isn't something that is available readily to us, to Black people. For racism, that's everywhere. And you can be put on the list for kidney transplant for years and years and years, and die without receiving it, okay? Because priorities are elsewhere for other ethnic groups. So that's why, if the prevention, I keep harping on prevention, because that's important. That means you're in control. You're in control. You can do something. You can delay it, not necessarily stop it, but you can delay it, and that's a good thing. That will allow you still to have a healthy and happy lifestyle.
Okay, thank you for that. And so the next question is, what about natural things like cinnamon? So I guess natural approaches to trying to prevent diabetes.
I will not just isolate one nutrient or macronutrient. What we do in our program, that is also part of success, is we have several nutritionists. We have one that is strictly plant-based nutritionist. And she has classes every week, every Thursday from 1 to 2:30. She breaks down food selection, the vegetables and fruit and so forth, emphasizing that you have to eat more fiber, food that has fiber, for several reasons. Fibers accelerate digestion, and it gives you that feeling of fullness, and it tricks your brain thinking that you're full. So you'll stop eating, and that's one of the good things. And it's food. Also, she does food preparation, and once a month, we go to Leisure World, where you can actually taste some of these, because it has to be palatable. If you're making a change, and those changes have to be gradual. It's not, you're not going to wake up one day and say, okay, that's it, I'm going to turn into a vegan No, it's a gradual change. So what we do, seeing the benefit of plant-based food, plant-based diet, we recommend that you eat as much vegetable as you can. Change it, the portion size, limit the fat, limit the protein, and you can eat as much vegetable as you want, as much fiber as you want, and that shows great benefit. So whether it's not, you can not pinpoint it to just one food. The danger with that is that people will think of that as, yes, food is medicine, but they will think that this is the same as having a bottle of pills that you take every day and it's going to cure you. It's the penicillin that'll get rid of that infection. No, and people, when they do that, they have a false sense of security about what diabetes is all about. And doing this thing, switching to plant-based food does improve the function of the brain and everything else, of the kidneys, and overall you'll feel better. And we've had people that give testimony after testimony after testimony. Each month we designate one of our clients as a health champion for the month. The one that we designated for the month of May actually switched to plant-based food 3 years ago, and she's saying she's about to put her blood pressure medicine in the rearview mirror, and her A1C is down to 5.4. Okay, you say you are told that you have prediabetes when that A1C is between 5.7% and 6.4. Above that is the diagnosis of diabetes. Below that, you have a normal blood sugar level. So again, that's anecdotal, but all the people that are doing it, they're doing better. They're doing better.
All right, so there are no more questions in the chat. Did you have more that you wanted to share about the diabetes prevention program? And you mentioned
Yes.
a survey that you had a link.
Okay.
Why don't you go ahead and go through that?
All right, let's do it. What is DPP? DPP is a diabetes prevention program. It's a nationally sponsored program by the CDC. And what we do, there are two things inside the class and what we ask people to do outside the class. We'll give you the tools. We give you a smart scale. We give you logs. And in exchange, all this is for free. All our program is free. I should mention that. We don't charge anything at all. Montgomery County has given us a contract. And any resident of Montgomery County can join in our program for free. And sometimes some of the neighboring residents can also join. So it's a Zoom class. And actually, when we started before COVID, we're meeting people in person, and we have live classes. And we couldn't do it. We can only do one such a week. But with the Zoom, we pivoted to Zoom during COVID, and we were able to do multiple classes all at the same time. So you get a login to the class, you get a weight scale, you weigh yourself, and we share the data with us, because this data we do submit it to CDC, and we ask you to be to participate in the class and set each week a plan of action, concrete things that you do, small steps that will lead to big improvement in your health. And this action plan, you work on it outside the class. That means logging your food index. Now we have the state of Maryland has created a platform. You sign it. You don't have to be present. You have this class I'm doing. It's called distance learning. I mean, every week we'll have lifestyle coaches to give the class, but we also have another approach where using the state of Maryland's platform. It's called HALT, and every week it gets a video and a lesson is dropped into your email box, and we ask you to listen to the video. The video is produced by CDC, and some of those action steps and so forth, and additional resources to read and to practice. And you, for instance, the type of food you're eating, you can take you download an app that would take a picture of the food you're eating, and it's with the magic of, I don't know if it's artificial AI or not, it will tell you the caloric content of your meal, so you know what you're consuming, and you share that. You have you can transmit that data to us, and your coach will email you. If you have questions, you can email your coach anytime, and they will respond. And also, one of the things, if you have a smart one of those speedometers that is built into your smartphone, you can share your physical activity minutes with us every week. Okay, and that's it. If you want a consult with a lifestyle coach, then one is always available to you. So we have those two approaches going. We started this one on the HALT platform recently. We don't know how well it's going to be, if we're going to get the same great results. Another things that we're doing, we receive funding from the NIH, the Office of Minority Health, and that is radically changing. You want to change the approach. Instead of focusing on the individual, we'll focus on the family. We think that if there is one person with diabetes within a family, chances are that another family member, remember, family member, that's one of the risks, is likely to have prediabetes. So we pair them up. The person with diabetes, we have a series of videos that is given to them for the first 12 weeks. Every week you get the video, and the person with diabetes is on the HALT, also following that track, and we encourage them to discuss what is they're doing. After 12 weeks, we bring them together for the next 4 sessions, and they all will be watching the same video and the same thing, and see what it is. So we enrolled 3 cohorts. Cohort A, that we started with in January, has ended. So we still have cohort B and cohort C that's progressing, and we will share that data with, there are other sites across the US that are doing the same study. And once they put together all this data, they'll determine whether it's a successful research protocol or not. So those are the different ways that we deal with prediabetes. So if you have never taken the test, I will ask you to get a piece of paper or just use your fingers, and we'll go through it. If you're male, give yourself 1 finger, count 1 finger. If you're a lady, don't worry, don't bother. it's okay. Well, we'll come to you in a little bit. If you are above, if you older than 45, give yourself another finger. If someone in your family has diabetes, give yourself 2 fingers. If you're not exercising at least 3 times a week for a minimum of 50 minutes, or 5 times a week for a minimum of 30 minutes, in total, 150 minutes of activity, moderate physical activity a week. If you're not doing that, give yourself another finger. And let's talk about weight. If your BMI is above 25, that means you're told that you're overweight, give yourself 1 finger. If you've been told that you're obese, give yourself 2 fingers. If you've been told that you're morbidly obese, give you 3 fingers. And count those fingers now. If you have more than 7 fingers, you have prediabetes, my friend. And since 86 million of Americans, adults, have it, it's simple. You somewhere, check to your left, that means 1 in 3 American has prediabetes. Check to your left, if the person next to you does not have prediabetes. Check to your right, if the person next to your right doesn't have prediabetes, you're the one, you have it. So if such is the case, you have more than 7 fingers counted, go and take the CDC test, or ask your primary care physician, ask your provider to give you a simple glucose test. And if they can't, if your insurance company allows to do an A1C for you, if they're not doing your A1C, you can always come to the African American Health Program. We'll do that for you.
Oh, wow. That's awesome. Do you have a slide that has your website or contact information? If not, I have it. I will make sure we share it with all the participants. And the last question I have is related to the cohorts that you have going. If our chapter wanted to get a group of people to participate in your DPP program, is that something that we would need to have further discussions about?
Yes, we can have a discussion about it, and this is a great idea. I would love to do it. If we have a minimum of 10 people, I will have a program just for your chapter, and we'll see. I have enough lifestyle coaches. The past 2 years, I've been the only one doing the DPP, and then I had the wisdom last year to have at least 6 staff members trained on doing the class, and that's why tonight I just welcome the participants, and my lifestyle coaches are doing the cohort.
All right. If there are no further questions, let me stop the screen real quick. I'll make some final remarks, and we'll hear from our first vice polemarch. I don't think our polemarch joined this evening. Just let's see, are there any other questions?
Oh, can you hear me?
Yes, sir.
Just as a sidebar, as part of his introduction, the learned doctor mentioned that he was sorry that he is not a member to be an alumni. Even though he's past 60, I just want to let him know that it's not too late.
That's right. Never too late, brother.
Okay.
As the national chairman of intake for our fraternity, I have taken in members in their 80s more than once. just a real quick, not to belabor, but a brother now in his 80s, he saw what Kappa did for his son, who became a member in alumni chapter. And he said, I have to find out what this organization that transformed my son, I have to join. So it's not too late. And I'll just put that out there for you.
Okay, thank you so much. I will consider it.
Very good, very good. All right. If there are no other questions or comments, I just want to, again, thank you, Dr. Dambita, for a very, very informative, very helpful presentation. And thank you for sharing the DPP program. And we will now have a remark or two from Dion Backus. If you're still on the call, he is one of our elected officers. And he's there, but his screen is dark, so I don't know if he's still there. Okay, so if not, I will just say on behalf of the Ninth Administration, Mark Ellington is our poll mark. We really appreciate your making time available to speak with us about diabetes, and we look forward to further discussions. I am very confident that we will have more than enough people to have a cohort associated with College Park, Sandy Spring, but I'll have some follow-up conversations with you